All right, thank you everybody for joining. My name is Shadi Reyes. I am cardiologist at DMC. I'm really privileged to be today with our co-host, Dr. Kenton Zer. He is our cardiovascular surgeon, as well as the president of the cardiovascular service line at Antithrombotic Medical Center. This is our monthly webinar coming from DMC Medical Group for heart to heart, and every fourth Thursday at 7 p.m. As you know, we have a monthly speaker from different specialty covering heart and vascular, from cardiology, cardiovascular surgery, as well as vascular surgery. And this is a CME activity, 1 credit. You're gonna receive a webinar survey at the end of the webinar and 1 week after, just to give us a quick review about your experience, and then you'll get your CME credit in the email. As you know, these webinars are hosted on our DMC Medical Group YouTube channel. They are, as I said, they are very diverse. It covers multiple topics that are really very handy for your practice. We're coming to you from Antithrombotic Medical Center, from Harper, Dr. Alkatib. He's our interventional cardiologist who practices at 2 sites. We'll come to introduce him in a second, but we'll start with this introduction video.
It weighs less than 1% of our body mass and is an engine that never stops, pumping almost 2,000 gallons of blood along 60,000 miles of blood vessels every day. Our hearts perform like nothing under the sun. So when your heart needs care, you want a team of experts, board-certified heart and vascular surgeons with over 40 years of combined surgical experience, trained at some of the nation's top institutions like Johns Hopkins University and Mayo Clinic. True specialists in the fields of non-invasive cardiology, interventional cardiology, cardiac electrophysiology, cardiothoracic surgery, and vascular surgery. For over 3 decades, our specialists have been available in Commerce and Detroit because we believe heart care isn't something you wait for. DMC Medical Group, trusted by the hearts of Metro Detroit.
We're privileged today to have Dr. Alkatib. He's interventional cardiologist at Antithrombotic Medical Center. He is practicing at Commerce Township at the Huron Valley Hospital, as well as at downtown DMC in the Heart Hospital, DMC Heart Hospital. Dr. Alkatib today will talk to us about what is new in antithrombotic therapy. This is a very important topic for medicine, cardiology, hematology. It's very diverse and very important. And recently, there is a lot of literature about this topic. Thank you, Dr. Alkatib, for being with us. And at this point, I will hand it to you.
Okay, thanks very much, Shadi and everyone, for the kind introduction. Today's topic will be antithrombotic therapy. Obviously, this is a huge topic, and it encompasses antiplatelet agents and the anticoagulants for a whole host of indications. My goal really here is to highlight, as Dr. Reyes said, kind of the newest, most relevant data as it pertains to everyday clinical practice. And so whether you're a prescriber of these medications, or you have to deal with complications of these medications, or if you're a surgeon who has to operate on a patient who's anticoagulated or platelet inhibited, this hopefully should be relevant to your practice. So the agenda for today, we're going to talk a bit about where aspirin stands in today's day and age as far as primary prevention and implications for bleeding. We'll talk about an approach that's somewhat new to patients meeting indication for triple therapy. What about patients who are anticoagulated and bleed or have bleeding problems or events? How do we manage them? And is there another option? And then we'll talk a bit about the new guidelines for perioperative management of the blood thinners. And finally, we'll end with a case of a cancer patient who develops VTE and what to do with them. But first, I'll share a story with you. And this is a story of 3 friends who got together over the summertime at a barbecue. And this was about the time where the U.S. Preventative Task Forces released their updated guideline, essentially abolishing aspirin for use in primary prevention for the vast majority of people. And so this was a major headline at the time. And so these friends had a discussion about that topic. And the first friend says that, many years ago, I found out through genetic testing that I have a predisposition to blood clot formation. What he had was factor V Leiden deficiency heterozygous. And many times I go on long car rides with my family, and the last thing I want is to develop a blood clot. And so for that reason, I take aspirin every day. The second friend chimes in and says, well, aspirin probably isn't good enough to prevent a blood clot. You probably need something stronger, like Xarelto or Eliquis, something prescription grade. How about the next time you go on a long car ride, you take one of those? The third friend gives his 2 cents and says, the reason they pulled aspirin from the recommendation is because it's causing a lot of gastrointestinal bleeding. But I also heard that an aspirin a day prevents colon cancer, and my grandfather died of colon cancer. And so for that reason, what I do is I take aspirin, but I take it every other day. And so you might hear this story and think, well, these guys are a little perhaps confused, misguided, and they should probably get the advice of a medical professional. The caveat here is that this discussion was had between 3 physicians, an internist, a cardiologist, and a gastroenterologist. And so this highlights the fact that there's a great deal of uncertainty when it comes to antithrombotic therapy, okay? We're constantly evaluating and balancing the risks. And think about how often we play the what if game. What if my patient has a stroke? Or what if she falls and hits her head and has a bleeding event or intracranial bleed? Or could I have prevented this bleed? Or could I have prevented this stroke? So it's a common dilemma that we face in everyday clinical practice. Guidelines can be helpful, but they can't always cover every patient scenario. So it falls upon us to make sound decisions based on evidence. And of course, involve the patient in the decision-making. So with that, we'll get into some of the data. Just this year, as I was alluding to, the U.S. Preventative Task Force has released their new updated guideline, which is long overdue, essentially saying, do not initiate aspirin for the vast majority of adults, certainly not in those ages 60 or over. In younger patients who have increased risk, the decision to start an aspirin regimen can be individualized, but they concede that the evidence to suggest any benefit is probably small. And so many of us have been following this for years, which is why I say it's a bit overdue. One of the main driving factors was to mitigate bleeding risk, particularly in the elderly. And so although the risk with aspirin is relatively small, when you apply that to the masses, it could be substantial in terms of total number of bleeding events. The other important note here is that it's estimated anywhere between 25 to up to 45% of adults over 40 are taking aspirin for primary prevention of cardiovascular disease. And now we know that that's probably not indicated. And so some patients may not consider aspirin even to be a medication. They may consider it to be a supplement. After all, it's been marketed for decades as a safe, effective drug for prevention of cardiovascular disease. But it's important for us as clinicians to know, first of all, is your patient taking aspirin? And if so, is it indicated? If not, a little education may be in order. Nonetheless, patients can become very attached to their daily aspirin use. So that's where a conversation is important. It becomes particularly relevant when your patient all of a sudden now has an indication for escalated therapy. For example, if they now have a new onset of atrial fibrillation and they require anticoagulation. Which brings us to the next point. What happens when you combine aspirin with anticoagulation? As far as the indications go, there are really just a few. Mechanical heart valves, acute coronary syndrome with an additional indication for anticoagulation, some cardiac devices such as LVADs, and a few other niche indications. But what happens when you treat patients with aspirin and an oral anticoagulant such as a DOAC when the indication for aspirin isn't quite clear? In other words, there really isn't an indication. How often does that happen? And what are the effects on bleeding, and what are the implications there? And so the authors of this study looked at a registry of over 3,000 patients who were on the DOACs, and they compared and propensity matched patients who are on DOAC alone and compared them to patients who are on DOAC and an aspirin, again, without a clear indication for aspirin. And here are the data. What they found was about a third of patients were treated with both a DOAC and aspirin, again, without clear indication. And here on the left are the bleeding outcomes for the various categories: new bleeding, non-major, major, and hospitalization or ED visit for bleeding. In the lighter shade, you'll see is the combination of DOAC plus aspirin. And across the board, there was significantly higher bleeding events compared to patients who are only on the DOAC alone. On the right-hand panel are the thrombosis outcomes. And as you can see, it's fairly similar. There's no major or significant difference. Now, the study is observational, and so that's one of the limitations, and certainly underpowered for thrombotic outcomes. But nevertheless, it raises awareness and certainly at least should make us as clinicians more aware of the risk and consider deprescribing aspirin when the risk outweighs the benefit. Again, this study looked at chronic or stable patients. It didn't include any acute coronary syndrome or anyone with a recent PCI. Which brings me to the next point and the first case example here of triple therapy in an AFib patient undergoing PCI. So this is a 77-year-old woman with permanent AFib presenting with chest pain. In addition to AFib, she's a diabetic. She has hyperlipidemia. She's on rivaroxaban, beta blocker, statin, metformin, and because of an abnormal stress test, she's referred for a coronary angiogram. And as you can see, she was found to have severe RCA disease and undergoes stent placement with drug-eluting stents, and a nice result there. And so now the patient has indication for triple therapy. When we say triple therapy, that means dual antiplatelet therapy plus an anticoagulant. So this patient was discharged the following day on medical therapy with aspirin, clopidogrel, and rivaroxaban. That's the triple therapy. And the plan was to treat her for 6 months, at which time the aspirin was to be discontinued to sort of reduce the bleeding risk. She was felt to be a low-risk patient. 2 months later, she was admitted to the intensive care unit with GI bleeding, found to have a gastric ulcer confirmed by endoscopy. And so what are the key considerations here for this case? How do we navigate the risk between stent thrombosis and major bleeding? You can ask any interventional cardiologist. One of our most dreaded complications is an acute stent thrombosis. It potentially has catastrophic results and outcomes. Certainly, we also don't want our patients to bleed. So when is the optimal time to de-escalate therapy? And then importantly, how do we tailor our treatment strategy based on the bleeding risk? And that could include your choice of antiplatelet agent. We know that some antiplatelet agents are more potent than others. And that also includes talk about our method of revascularization. In the cath lab, we have balloon angioplasty, we have bare metal stents, drug-eluting stents. And we also should consider surgical revascularization when indicated, where a surgeon potentially could do a bypass and ligate the left atrial appendage, potentially eliminating the need for an anticoagulant. So that's something to consider. And much of the data on triple therapy and de-escalation comes from the Augustus trial. So the Augustus trial included patients who had atrial fibrillation, who then had an acute coronary syndrome or underwent PCI. And so they now have indication for triple therapy. These patients were randomized to receive either apixaban or a vitamin K antagonist, warfarin. And they were then randomized to receive either aspirin or a placebo. All patients were also given a P2Y12 inhibitor. By and large, the vast majority, that was clopidogrel. So you could have patients on apixaban, aspirin plus clopidogrel, apixaban placebo, clopidogrel, warfarin, placebo, clopidogrel, etc. Okay, and so this was an international study including a good number of patients, 4,600. And the primary outcome they looked at was major or clinically relevant bleeding. They also looked at a composite of death or hospitalization. And the treatment time on triple therapy was 6 months. And so here is the primary outcome. Again, major or clinically relevant non-major bleeding defined by the ISTH. What you'll see here is on the left that bleeding events were significantly lower with patients who are on apixaban versus warfarin. And this met the criteria for both non-inferiority and for superiority. And this is what we've known from prior studies. And it's generally widely accepted that the DOACs, again, in general, have a better safety profile when it comes to bleeding. On the right, comparing aspirin and placebo, you'll see that patients assigned to placebo had significantly less bleeding events compared to aspirin. Again, all these patients were additionally on anticoagulant plus a P2Y12 inhibitor. When you look at the combined endpoint of death or hospitalization, apixaban was actually superior to warfarin, albeit a very small magnitude of difference. And there was no difference with aspirin versus placebo. And so the combination in this trial that had the best, safest outcome was the apixaban placebo arm. So in other words, apixaban plus clopidogrel. And so this suggests the safety of de-escalating triple therapy to dual therapy. And the question then becomes, well, when is the best or optimal time? There's no definite rule, but it appears that based on subsequent analyses of this study that around the 30-day mark may be sort of the sweet spot. Okay, after 30 days, there appears to be little to no benefit of extending therapy for the majority of patients. But there are some caveats. So this brings up the concept of a patient-tailored approach to antithrombotic therapy following PCI. And so how do we risk stratify? This is the key. How do we predict who's going to bleed or who might have a thrombotic event? Of course, there's no substitute for good clinical judgment. Sometimes you just have a hunch, right? Risk scores can be helpful as far as predicting, but they do have their limitations. Certainly, the complexity of the PCI matters, and I would encourage you to reach out to your interventional colleagues to get a sense of the complexity and extent of the PCI that was performed. You know, was there left main stenting involved? Was there bifurcation? Was there long diffuse stenting done? Or was there any suboptimal result? Was there underexpansion, for example? All these factors matter in terms of escalation or de-escalation of antiplatelet therapy. There may be a future role for genetic testing and perhaps even platelet function testing to help further risk stratify. And here are two very commonly used risk scoring systems. On the left here, the famous, well-known CHADS-VASc score for atrial fibrillation, which have the criteria that you see here. I'll point out that for there's additional consideration, 2 points for stroke or TIA and for the elderly. And what you'll see is that as the CHADS-VASc score rises, so does the annual stroke rate. On the right hand is a scoring system called the Hasbled score, which is used for predicting bleeding events. Some of the criteria are on both sides, such as hypertension, stroke, elderly patients. And again, as with a rising Has blood score, the risk of major bleeding increases as well. I find the Has blood score personally, just anecdotally, to be maybe not as helpful in clinical practice. And the only reason I say that is because I've seen plenty of patients who bleed, who have, low or even zero Has blood scores, but nevertheless, it does have some use. And so your next step is to really determine where your patient falls here, okay? Take, for example, a patient with a low bleeding risk who has a high ischemic risk. And your goal in those patients really is to reduce the risk of thrombotic events. And so in these patients, you may want to extend or escalate antithrombotic therapy and treat them a little longer and perhaps with more potent agents. On the flip side, anyone who's a high bleeding risk, regardless of their ischemic risk, your primary goal here is to decrease bleeding events. And so these are patients who you want to shorten or de-escalate antithrombotic therapy as soon as possible. In the middle, you can use probably standard therapy and standard intensity. And this way you overall achieve a net clinical benefit while reducing the risk as much as possible. What are the factors that favor shortened or de-escalated antithrombotic therapy? Certainly anyone with a history of bleeding or on triple therapy, if they're anemic or thrombocytopenic at baseline, if they have malignancy, these are factors where you want to pull back and scale back the antithrombotic therapy sooner rather than later. There are factors that are on both sides of the equation. For example, age. We know that the elderly bleed more, but they also thrombose more. And that holds true for diabetics and patients with renal disease. Factors favoring extended or escalated therapy include anyone with an acute coronary syndrome. Those patients can be highly thrombotic. Again, complex or extensive CAD or extensive PCI. Anyone with a prior MI, or again, extensive vascular disease, these are patients who you may want to escalate or extend therapy. Historically,
Aziz, is there a role here for GI, since a lot of the bleeds are GI, is there a role to categorize people by doing GI diagnostic procedures to rule out a propensity to bleed from their GI tract, to maybe extend their course if they're higher risk for ischemic events?
Yeah, that's a good question. I don't know. I think the only factor that we can count on for sure is a history of GI bleeding.
But you don't take a patient and say, look, I'd love to stop to slow down your anticoagulation, but let's do an upper GI, make sure everything's okay, no gastritis, no ulcer disease, or a lower GI to look for AV malformations or anything like that.
Yeah, no, I think in the absence of symptoms or an episode or index of bleeding, I don't believe that would be necessarily indicated. I don't do that in my practice necessarily. No. Yeah, so it's a good thought. So historically, dual antiplatelet therapy was prescribed for at least 12 months. This was hounded to me as a fellow, okay? You get a stent, you're on dual antiplatelet therapy, uninterrupted for 12 months. So that was really studied with the very first generation of the drug-eluting stents. And it was due to a concern for very late stent thrombosis. The newer generation of drug-eluting stents have considerably lower rates of late stent thrombosis. Okay, so some trials have now looked at a shortened or reduction in bleeding events without an increased risk of ischemic events using a short course of DAPT. And that has been studied anywhere between 3 and 6 months. And there's actually studies looking at as short as a 30-day duration. Keep in mind, though, these are for patients who are relatively low risk of thrombotic events. Patients who are at higher risk require further consideration. The trial composites that are used frequently, they combine ischemic events and major bleeding. And that can be a little misleading because the individual endpoints can have varying impacts on the patient's life. For example, bleeding, it can be a nuisance, of course, and can be majorly problematic, but it's rarely fatal and it's rarely disabling. A stroke, however, obviously can result in permanent disability. That brings us to the next case for discussion. This is an 82-year-old woman with
Aziz,
yeah.
A quick question before you go to the next case.
Sure.
We have a question from the audience saying, any specific recommendation in patients who have advanced CKD or patients who are already on hemodialysis?
Yeah, so that poses a challenge a lot of times because those patients, again, as you saw there on both sides of the equation, right? They tend to bleed more and they tend to thrombose more. And so they're particularly challenging. As far as the DOACs are concerned, really the only one that is approved for use in dialysis patients specifically is the apixaban. And so, again, you want to take into account other risk factors to determine how they're going to tolerate that long term. If this is a patient who you're worried about bleeding, you may want to scale back sooner than later, but if they have extensive CAD, perhaps you want to lengthen their therapy. But yeah, the dialysis patients pose a particular challenge, certainly.
Thank you.
Sure. So this next case example is an 82-year-old woman with newly diagnosed AFib. She has hypertension, hyperlipidemia, osteoarthritis. She takes losartan, a statin, and PRN naproxen for her osteoarthritis. You can see her vital signs there. She weighs 78 kilos and her renal function is normal. So with a newly diagnosed AFib patient, one of the first things you want to do is calculate their CHADS-VASc score, and she scores a 4, which meets indication for anticoagulation. And so she has started on apixaban 5 milligrams twice a day, and that is the correct dose based on her age, her having a body weight above 60 kilos and having normal renal function. 2 months later, she has dark tarry stools, she's lightheaded, she's admitted with GI bleeding, requires a blood transfusion, she gets scoped, and there's a gastric ulcer without active bleeding. And she tells you that in the previous weeks, she's been taking NSAIDs more than usual for her arthritis. So the question here is what to do next. Obviously, you're going to stop the NSAID and you're going to get her on PPI therapy. But what should you do in terms of stroke prophylaxis for her moving forward? And do you switch to an aspirin? Her risk of recurrence is too high, and maybe you should put her on aspirin. Should you bite the bullet and resume apixaban at the 5 milligram dose? Should you resume apixaban but reduce the dose to 2.5 milligrams twice a day? Switch to clopidogrel or switch to warfarin targeting a lower INR goal? And so of these, really the best answer here is to resume apixaban 5 milligrams twice a day. And the short explanation here is that none of the other options listed will provide adequate stroke protection. Okay. What I often see done is I see patients getting put back on a reduced dose of apixaban, which intuitively makes sense to sort of mitigate the bleeding risk, but there is real world data to show clearly that those patients are not fully protected in terms of stroke reduction.
Aziz, what's the role for a watchman in a patient like this?
I'm glad you asked. We'll get to that very soon. This is the decision, so whether or not to resume anticoagulation after a bleeding event is, again, a matter of weighing the risks of bleeding, recurrent bleeding, or thromboembolism. So this was data from a meta-analysis where the authors looked at what happens when you resume an oral anticoagulant versus not in patients who have a GI bleeding event. And what you'll see is that for patients who discontinued their anticoagulant, their rate of recurrent bleeding was much less. That's kind of makes sense, but that came at a cost of higher risk of thromboembolism and a slightly higher mortality risk. Okay, so again, this highlights the challenges that we face, and when the data, where the data really is lacking is to answer the question of when is the right time to resume after a bleeding event. There really isn't much data, but some have suggested around the 3 to 6 week range might be reasonable. I tend to wait. Sometimes the GI physician will clear a patient to go back on anticoagulation, but oftentimes I'll wait a bit longer to make sure they've healed. And getting to Dr. Zier's question, what about the left atrial appendage occlusion? So this provides an alternative to oral anticoagulation in terms of preventing thromboembolism in patients with non-valvular atrial fibrillation. And so this was approved in 2015 and has been around for years, but nowadays is gaining in popularity. So how does this work? Well, it's estimated that over 90% of blood clots that are responsible for strokes in AFib originate in the left atrial appendage. And so when you occlude this over time, this becomes endothelialized and you essentially exclude the left atrial appendage from the circulation, thus reducing the stroke risk, and without having to resort to oral anticoagulation. And so this has become a really nice option for patients who anticoagulation simply becomes risk prohibitive, and even it becomes a matter of patient preference. And so, I'm happy to say that many of my colleagues at the DMC perform this procedure. It's pretty straightforward with very high success rate. So it's a nice option as an alternative to anticoagulation. And even more good news is the news surrounding the most recent iteration of the Watchman device, the so-called Watchman Flex. Previously, patients would need to be on aspirin plus anticoagulation for 45 days after device implant. And we know that for some patients who are very high risk for bleeding, any anticoagulation is simply not an option. And so they were potentially excluded from implant. The FDA very recently approved an alternative drug regimen post-implant, which does not include anticoagulation. These patients simply can be on dual antiplatelet therapy, aspirin, clopidogrel, for example, for a total of 6 months, followed by a low-dose aspirin after that. So this is great news for patients who cannot tolerate or prefer not to be on anticoagulation, but still need to be protected from stroke. Okay, so I have to talk a little bit about this because we've all encountered this, right? In fact, about 2 days ago, I got a phone call from a patient about this. My nose keeps bleeding, and it's usually followed by, can I stop my Plavix, Eliquis, Xarelto, et cetera, what have you? And the answer to that is usually no, you cannot, okay? So epistaxis can be anything from a minor inconvenience to a middle of the night trip to the ER. Well, what's important to know, really, how do we manage this? Important to know that the vast majority, 80 to 90% of nosebleeds originate in the anterior nasal cavity, specifically in this confluence of vessels referred to as Little's area. The other 10 to 20% occurs in the posterior nasal cavity, which can be more challenging to treat. Well, with that being said, what is the proper initial step in stopping a nosebleed? And it's simply digital compression of the lower third of the nose and hold pressure for 15 to 20 minutes while holding the head forward. Okay, so none of this giant wad of Kleenex and tilting your head back business, okay? This way you tamponade the anterior vessels and you're preventing aspiration and swallowing of blood. Now, if this is unsuccessful, then yeah, you can go down this pathway that requires an exam and potentially cautery or packing, or in extreme cases, holding of antiplatelet therapy and even platelet transfusions. And depending on where you are, that could be in a clinic setting or in an emergency room. But these are a minority, okay? So once you've controlled things, really the next step is to prevent recurrence. And this is where a little education goes a long way. Avoid blowing your nose. So for some reason, when patients stop their nosebleed, the first thing they want to do is blow their nose. And that's a surefire way to start the bleeding again. So tell them not to blow their nose. Avoid digital manipulation. Of course, the response will always be, "Doctor, I don't do that." That's okay. Remind them anyway. And what I find particularly helpful is to recommend nasal saline rinses or sometimes gels, and particularly in the winter months, to sleep with a humidifier in the bedroom. I find that helps reduce the risk of these recurrent nosebleeds. Okay, switching gears to talk now about perioperative management. The chest guidelines were very recently updated, and they highlight the best practices for managing antithrombotic therapy in the perioperative setting. It's an extensive document. I'm only going to highlight a couple of points, but for anyone who's interested, I would refer them to this, this newly published or updated guideline. And so, can you clear my patient? This is the next case of a 68-year-old woman with atrial fibrillation. She has hypertension, diabetes, heart failure, and prior TIA, which gives her a very high CHA2DS2-VASc score of 7. She's taking an oral anticoagulant, and for the purposes of this example, that could be apixaban, rivaroxaban, or even warfarin. And she's scheduled for a hip replacement in a week with spinal anesthesia. And so what are the questions that come to mind here? How do you assess the risk of bleeding? How do you assess for risk of thrombosis? When is the right time to interrupt anticoagulation? And certainly, when do I need to bridge, or what circumstances would I need to bridge this patient with low molecular weight heparin? And in terms of the risks for patients with AFib or with a mechanical heart valve, the risk of what you worry about is stroke or systemic embolism. For patients who are on anticoagulation for venous thromboembolism, what you really need to be concerned with is, are they going to have a recurrent VTE while they're holding their blood thinners? And here's a chart that sort of highlights the thromboembolic risk. For example, atrial fibrillation. And this is quite simple. The highest risk patients are those with the highest CHA2DS2 scores. Okay, and certainly anyone with a recent stroke within 3 months or TIA would be considered high risk. On the opposite end, the low CHA2DS2 score risks are considered, low risk for thromboembolic events while you hold their anticoagulation. For the mechanical heart valves, the older generation valves, the ball and cage or tilting disc type valves are considered high risk. The valves in the mitral position, again, the mechanical valves in the mitral position, are generally considered a higher risk, although there's some new data that may challenge that, which I'll show. Again, anyone with a recent stroke or TIA. The lower risk valves are the aortic position mechanical valves, depending on whether they have additional risk factors. On the venous thromboembolism side, any event that occurred within the past 3 months or that is associated with an inherited thrombophilia are potentially high risk. Any VTE that happened more than 12 months ago are the low risk patients. And in a similar fashion, the bleeding risk with the type of surgery can be categorized based on the type of surgery and the expected blood loss. And so on the low end of the spectrum are these minor dermatologic procedures, cataract procedures, dental procedures, and I'll point out specifically here pacemaker or defibrillator implants. These are considered low risk, and oftentimes anticoagulation does not need to be held for these procedures. And in fact, there's actually very good data in favor of not holding anticoagulation specifically for pacemaker or defibrillator implants. On the next scale up are the minor procedures, such as minor orthopedic procedures, cardiac catheterization, lap choles, abdominal hernia repair. Everything else, which is a pretty comprehensive list, belongs in the high-risk category. So any major orthopedic hip, knee replacements, GI, GU surgeries, certainly cardiac surgery falls in here, and any operation that's considerable duration are high risk. And so, armed with this information, your next task is in your mind to sort of pinpoint where your patient falls between the two risk categories. Again, for minimal bleeding risk procedures, there's probably no need to hold anticoagulation at all. For the highest thromboembolic risk procedures, these are the ones where you need to consider bridging. And so I'll talk about the PERIOP 2 trial, which looked at bridging with low molecular weight heparin in the post-operative setting. Prior to this, we had the BRIDGE trial, which looked which really provided much of the basis for the recommendations surrounding bridging before surgery. The BRIDGE trial primarily included atrial fibrillation patients who are on warfarin. This trial, on the other hand, also included mechanical heart valve patients, a good number, a small number, but a good number nonetheless, and that included both in the aortic and in the mitral positions. And so this scheme here is a little complicated, but very simply, the patients, stopped their warfarin, and after the procedure, they were either started back on warfarin with low molecular weight bridging or with placebo. And these were the outcomes. For the outcome of major thromboembolism, there was no significant difference between those who were bridged and those who were not bridged. And that was also true for the combined outcomes that included major bleeding and death. And so the guideline committee concluded with these new recommendations. For atrial fibrillation patients who need to stop warfarin for surgery, we recommend against heparin bridging, and they note that's a strong recommendation based on a moderate certainty of evidence. For the mechanical heart valve patients, they also suggest against heparin bridging, but concede that it's a conditional recommendation based on relatively low certainty of evidence. The important caveat here is that any patient considered or classified as high risk, those patients should be considered for heparin bridging. And again, who are these high-risk patients? The older generation of valves, mechanical valves with additional risk factors, the very, very high stroke risk patients, for example. So, this has the potential to be practice changing, but I think perhaps more data and more of a consensus is needed, particularly for the mechanical heart valves. All right, final topic and final case example is cancer-associated VTE. This is a 52-year-old who presents with left lower extremity pain, swelling, and redness. She has active breast cancer undergoing treatment. And a venous Doppler confirms that she has a DVT, and she's therefore started on enoxaparin at 1 milligram per kilogram twice daily. And you are now consulted to determine her anticoagulation regimen moving forward. And so what do? Do you continue low molecular weight heparin? Should you transition her to warfarin? Or should you consider a DOAC? And the other correlate to that is how long should she be treated? Is this provoked or not? Should she be on 3 months, 6 months, 12 months, or should she be on indefinite? I can tell you there's not a lot of data regarding the duration of treatment for the cancer-associated VTEs, but it's generally accepted that the treatment should be indefinite while the cancer is active. The annual incidence of VTE in cancer patients is about 1 out of 200, and it accounts for a pretty substantial portion of the total mortality in a group of cancer patients in the outpatient setting, about 9%. And where does the data on the DOACs come from? There are 3 landmark trials that studied specifically treatment of VTE in cancer patients. They included edoxaban, rivaroxaban, and apixaban, most recently with apixaban, and these were compared to low molecular weight heparin, which is considered the standard, again, for cancer patients, and you can see the various trial characteristics here. And when they meta-analyzed the data for recurrent VTE, they found that DOACs decrease the risk of recurrent VTE better than the comparison, which was low molecular weight heparin. There was a non-significant increase in the risk of major bleeding, however. And so what are the do's and don'ts? I think for any cancer-associated VT now, we have good data to support the use of the DOACs, specifically these, or of course, low molecular weight heparin. I would not use warfarin unless really the patient couldn't tolerate a DOAC or can't afford a DOAC or low molecular weight heparin. There are other considerations, their renal function, their hepatic function, the overall risk. Caution using DOACs in patients with high bleeding risk cancers, specifically the GI and GU cancers, as there could be a slightly higher bleeding risk. So that should be considered. And then, of course, the potential for any drug-drug interactions with the DOACs and the patient's chemotherapy. And so to summarize, I'll just sort of pose these questions. Number one, does my patient need to be on aspirin? Ask yourself this, okay? Especially important to ask when the patient now has an indication to be on other therapy, oral anticoagulation. Is this a situation where the aspirin was just carried over, and can it be discontinued? And it's a question sometimes of who owns it. Sometimes the primary care doctor will say, well, it's up to the cardiologist. The cardiologist may say, well, it's not up to me, it's up to the hematologist or the primary care doctor, et cetera. Transition from triple therapy to dual therapy as soon as possible, and reach out to your cardiovascular colleagues to determine perhaps the optimal timing for that, and advocate for de-escalation in high risk, high bleeding risk patients. Should we resume anticoagulation after a bleeding event, or is left atrial appendage occlusion perhaps a better option? Obviously, this pertains to AFib patients. Sometimes you have no alternative for other indications, and so you're left to determine when is the right timing to resume anticoagulation. Does this patient need to be bridged for surgery? I can tell you that the answer to that is probably no. Only about 20% of AFib mechanical valve patients fall into that high risk category. The vast majority probably do not need to be bridged. And then finally, how best to treat my cancer patients' VTE. I think there's good data now supporting DOAC use. And of course, low molecular weight heparin is always an option. And with that, I will conclude. And hopefully we can answer some questions and have time for discussion.
Thank you so much, Dr. Alkatib. Very, very insightful presentation. A lot of data to digest, but it's interesting scenarios. We have a few questions from the audience. Again, for the people on the call, please use the Q&A box to ask any questions, or the chat if you have any questions to Dr. Alkatib related to antithrombotic therapy. Question from Dr. Shadi Saad of how soon can we resume back apixaban or any NOAC after the GI bleed?
Yeah. So I in my personal practice, I like to wait at least 2 weeks First things first, I definitely want to get the insight from the endoscopist, right? Was there active bleeding? What was the extent of bleeding? You want to understand that. But there is, there's no hard data on this, but generally around the 3 to 6 week mark. It depends somewhat on their risk. If it's a lower CHADS risk patient, I might wait 3-4 weeks. I've waited longer even. Sometimes I've waited until the patient has another endoscopy and follow-up, perhaps 6 to 8 weeks later, to ensure that things have healed. And then when I get that confirmation, I'll start the patient back on their anticoagulation.
Yep.
I think for lower risk patients, it's okay to wait. It's acceptable.
As you said, the insight from the gastroenterologist or GI team or surgery is very important for the timing. If it is a polyp versus as a bleeding ulcer and clipping.
Exactly.
Other question is, does finding pathology on EGD as a cause of bleeding contribute to when to resume the anticoagulant? I think we touched that already, which is already answered in the previous question. Thank you so much, Dr. Noureddin, for your question. Other question related to the Watchman Flex. Can we just use NOAC for 45 days for Flex, for the Watchman Flex?
You can. So you can. That's option one. You can use 45 days of anticoagulation. So that was the standard prior to the new, updated regimen. So that's option for patients who cannot. Then you have the dual antiplatelet therapy option.
Okay, but as you know, as the audience know, that the purpose of putting Watchman is to take the patient off the anticoagulation.
Exactly.
Although there was some FDA requirement to have anticoagulation for 45 days, now this is kind of taken out for only dual antiplatelet. Just for the.
Let me ask you this, Dr. Alrez. Who would you consider sort of the ideal candidate for a Watchman or left atrial appendage occlusion procedure? What's your threshold? When do you decide that this is what the patient should get?
Well, it's as you illustrated beautifully, it's very objective. There's no guessing game here. If your CHAS-VASc score, if the patient CHAS-VASc score is high, meaning your risk of annual stroke 2.1% or higher due to CHF or heart failure, gender or ACS or PAD disease, and also the has-bled is high, more than 2 and 2, I think this patient should be a candidate. Now, some patient, as you know, we have a trial of anticoagulation that's been the standard of care, where you start NOAC or DOAC for these patients and if they have an incident where they are falling, risk of intracranial hemorrhage, or if they have risk of recurrent GI bleed requiring transfusion, this is no brainer. These patients are qualified for Watchman, and this is, I think, a good alternative for them to take them off.
Yeah, and I'll also add that patient preference matters too. You have patients who simply either are non-compliant or they simply don't want to take an anticoagulation, and that potentially could be considered in the decision making.
100%.
Let me ask Dr. Zair, when do you decide to clip surgically a left atrial appendage? When you're doing a bypass or a valve? First of all, how complicated a procedure is that, and when do you decide to do that or not?
It's a good question, and it's evolving. The devices are relatively expensive, even though they're a very simple clip. It's basically like a cloth. It's like a cloth reinforced hair clip that just clips at the base of the appendage. It takes 5 seconds. It's simple, simple, simple. In fact, it's so simple now that there's a new Michigan cooperative initiative that all patients that have any history of paroxysmal atrial fibrillation should be clipped at the time of their cardiac surgical procedure, and that is now a metric. It's expected that we're 100% compliant with that. It started out as just with coronaries. Now it's become all procedures. So all surgical procedures to go to the operating room with paroxysmal atrial fibrillation should be clipped with a clipping device within 1 centimeter of the base of the appendage and confirm that you're there by a TEE. So that has now become the norm. So part of our timeout in the operating room is, does this patient have any history of paroxysmal atrial fibrillation? And if so, we clip that appendage. Now, there is a move afoot that says that all patients undergoing cardiac surgery probably should be clipped. Personally, I don't see a downside with that other than expense. And I think that's the direction that we will go, because we have so many more problems with bleeding, in these patients that are on anticoagulation. But as you know, in several decades of practice, there's been an incredibly evolving standards as to regard to how to treat patients that have an indication or not an indication for for anticoagulation. And I've seen in the last 20 years, I've seen us go from anticoagulating mitral valve repairs that have a simple cloth band with warfarin for 3 months to doing none.
Yeah,
And
the trend is definitely less is more. That's
right.
definitely
And when I started my practice, we anticoagulated all tissue valves in any position for 3 months with warfarin. Now none of them get it, and it's just an antiplatelet agent.
Yep. And now even for the mechanical mitral valves, it's always been aspirin, warfarin. They're even sort of de-emphasizing that aspirin for those patients.
Exactly.
Always got them.
The other issue that's evolved a lot is, and you brought it up, is bridging.
Yeah.
We bridged everybody, even in the aortic position, for a cardiac or for a non-cardiac surgical procedure. Now we're well aware that you don't need to bridge aortics for sure. Yep. I still think you probably should bridge mechanical mitrals.
I'm with you. I'm with you on that.
Maybe I'm old school about that, but I think mechanical mitrals should be bridged.
Yeah, I'm glad we brought this up, because I was going to ask your opinion on that specifically, because these new guidelines potentially, challenge that. For us as cardiologists, I mean, mechanical mitral valve equals bridging. I mean, those we've always done that, and I think we'll probably continue to do that until there's more data. But potentially down the road, that could fall away in patients who are otherwise low risk, who have a straightforward mechanical mitral valve but no other risk factors. Maybe they don't need to be bridged. But
as we're all on this panel well aware that with the new Onyx bileaflet mechanical valve, the indications for using lower anticoagulation are clear, and therefore bridging probably doesn't need to be a reality for an Onyx mitral anymore. But I'm not sure that that's true yet, because we don't have data there yet. I certainly think it's true for the aortic position, when the FDA has allowed us to keep our patients between 1.5 and 2 after 90 days of insertion of an Onyx aortic valve.
Yeah, great points. Let me ask. Oh, you have another question, Dr. Weiss?
Yeah. We're just after the hour, just to make sure we cover all the audience.
Sure.
Iman is asking, what is your recommendation for COVID-related DVT/PE prevention in patient, like in hospital or after discharge?
Yeah, that's a great question. And there are data looking at this specifically. I personally don't know the data very well. I'll be honest on that. But it is an area of active study and interest. But I generally treat them a little more aggressively as far as prophylaxis and getting them on therapeutic anticoagulation as soon as possible. For patients who have massive or submassive PE, we frequently offer those patients more advanced therapies, catheter-directed therapies, thrombectomy, lysis, etc.
Another question from Ahmed Abdeen asking, how soon do you resume anticoagulation after acute CVA in the setting of atrial fibrillation and LV thrombus after acute MI? So I think two different questions.
Yeah.
When do you resume anticoagulation after CVA and after LV thrombus, and what is the agent of choice?
So for LV thrombus specifically, there's really, unless there's a bleeding issue, I see no reason, to wait. If they're in the throes of an acute MI, there is inflammation and perhaps a higher risk of hemorrhagic pericarditis. But I think nowadays, with PCI being the standard and early revascularization after acute coronary syndrome being the standard, I think the risk of that is low. So I have no problem starting a patient on anticoagulation shortly after an acute MI if they have a left atrial thrombus. The DOACs would be considered off-label for that, but it's done all the time.
It's very important to highlight that warfarin is the standard of care for LV thrombus, but off-label use of especially apixaban, rivaroxaban has been recommended. Okay. Other question from John is, what is your opinion on who is at high risk of DVT, 80-year-old, and anticoagulation who's at risk for fall? Meaning, how do you balance that?
Yeah, that's always a tough one. I think fall is something that tends to be overused as an excuse not to be on anticoagulation. I think elderly, they fall, they are at risk, but how often does a fall result in a clinically significant bleed? I think that is a relatively small number. So I think, you don't want them to extend their venous thromboembolism or have a PE. So those patients really need to be on anticoagulation. I don't think IVC filter is a very good alternative. So they need to be on anticoagulation. I favor apixaban in those patients. And again, make sure their other risks are accounted for. If they're on aspirin and they don't need to be, get them off the aspirin, reduce their risk to the lowest, escalation possible, and just monitor.
All right. So, Dr. Alkatib, really, we would like to thank you for your time and very insightful presentation on the management of antithrombotic, highlighting the most recent guideline and recommendation. To the audience, thank you so much for joining us for the full hour, and we're a few minutes after. We have more than 50 audience on the webinar. Thank you so much for joining us and make this a great success. This is an AMA PRA category 1 credit. You're going to get a survey in a few days, and once you fill that, you're going to get your CME accredited certificate. Also, DMC Medical Group covers different specialties. This is a general number. If you have any referrals for any specialties, especially cardiovascular and cardiology referrals. Finally, I would like to highlight the transfer center for any emergencies. We have been asked about this number a lot. So please make a note if you have any emergency to be transferred. And finally, I would like to thank the planning committee for the webinars, Elise Bennett for our marketing team, Sherry Alvarado, who is our cardiovascular administrator for TPR and DMC Medical Group, Dr. Zer for being phenomenal, our speaker as well as a co-host, and all the planning that happens behind these webinars that has been building up for the last 2 years, starting from COVID pandemic till now. And the biggest thanks is to our audience for sticking with us for the whole hour, and our success is part of your engagement. And definitely, we always look for new topics. So once you get that survey in the email, please fill it up and share your experience and what topic you'd like to hear. Dr. Zer, any final comments?
No, I mean, I applaud everything you said. We really do want to hear from the audience. We really want to hear what topics you're interested in. We're also interested in potentially showcasing some other subspecialties on here as well. So let us know who you'd like to hear from. Would you like to see some orthopedic physicians on this channel? Would you like to see OBGYN? What questions would you like answered?
Absolutely. Again, big thanks to our speaker, Dr. Alkatib. Thanks for a very insightful presentation, and everybody have a good night, and we'll see you next month.
Thank you so much.
I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.